From our previous videos, we now know that the pharyngeal swallowing is an intricate temporal arrangement of oral cavity, oropharynx, larynx, esophagus to transfer a bolus of food from mouth to stomach while protecting the airway at the same time. And this complex procedure is regulated by a central pattern generator located in the nucleus tractus solitarius, which is stimulated by the sensory inputs from the pharynx, the oropharynx, the laryngopharynx, and the upper esophageal sphincter. And it all depends upon the physiochemical properties of the bolus. So videofluroscopy was first given by Jerry Logman, and she developed it and first reported it in her book in 1983. And that book also focused on speech, voice, and swallowing using radiographic studies. The graph on the right hand side summarizes whatever I said just now. The swallowing starts when the bolus of the food is propelled with a thrust from the tongue base with a pressure of 130 plus minus 70 millimeters of mercury and the glossopalatal junction opening. That is the oral propulsive phase. And it takes around 0.4 seconds for the pharyngeal reconfiguration and until the laryngeal vestibule closes. Now the black column is the time taken for the from the food bolus from the velopharyngeal closure till the upper esophageal sphincter opening, and this black column represents a time delay which depends on the volume of the bolus, the consistency of the bolus. So a bolus that is around 10 to 15 ml will usually show a delay of zero point 0.1 millisecond, but a bolus that is more than 20 ml will show a delay of more than zero point 0.2 seconds, and the bolus of the food is passed down beyond the upper esophageal sphincter in 1 second. So why are we studying pharyngeal dysphagia? How common it is? So it is seen 30% of CVA patients, around 50 to 80% of Parkinsonism patient, 84% of the Alzheimer's disease patients, 60% cases of head and neck cancer patients, 7% of patients post general anesthesia, 69% of the tracheostomized patients, more than 60% of the elderly institutionalized patients, and about 10 to 20% of GERD patients, and 40% of the adults above the age of 65 years, they have some form of dysphagia. So why is this age-related dysphagia present? So because there are some age-related changes, there is sarcopenia, that is muscle weakness, there is decreased lingual pressure, thinning and atrophy of the muscular and the ligamentous structures that is involved in the structures involved in the swallowing. Also, there is a generalized laxity and loss of muscular tone um, in the patient. So we can see the pharyngeal spaces like the vallecula or the piriform fosses are little more dilated than in a young adult. And there are some functional changes also, like slower rate of swallowing, loss of normal smooth peristaltic waves, and a more segmental type of propulsion with some degree of incoordination, which is frequently observed. So this is a general difference between a video fluoroscopic swallowing study and a fiber optic endoscopic evaluation of swallowing. So mainly I'll talk about the advantages of VFSS, that it permits real-time assessment of all the four phases of swallowing, and we can at the same time give immediate recommendation for safe swallowing practice. Whereas the oral phase is usually missed in fiber optic evaluation of swallowing. The disadvantages of VFSS are that it requires a different suite where we need all the machines for a fluoroscopic study. Plus, there is radiation exposure. But I'll let you know that for a 3 to 4 minutes study of a video fluoroscopic study, it will give radiation equivalent to only 2 cervical esophagograms. Uh, there is limited anatomical assessment, not much, and there is inter observer variability, and there is less reliability. So first we'll talk about the penetration aspiration scale. It was given by Rosenbach et al. In 1996, where he classified the penetration aspiration of food into the airway from 1 to 8. 1 where there was no penetration or aspiration, and 8 where there was silent aspiration. So 2 and 3 deals with the food bolus which stays above the focal folds in the region of supraglottis, 4 and 5 in the region of glottis, and 6 to 8 in the region of subglottis and trachea. So we'll see each one of them individually. Before going on to penetration aspiration scale, we should know how a videofluoroscopic study gets recorded. So patient is usually positioned first in the lateral view to take a check fluoroscopic image, and the regions of visualization includes the oral cavity, the pharyngeal cavity, the larynx, and the cervical esophagus, as you can see. Then the patient is positioned in the usual eating or drinking position, that is the frontal view or the anteroposterior view, so that the judgments regarding the symmetry of the bolus flow, the pharyngeal wall contraction, and the symmetry of the structures and functioning can be viewed during the bolus flow. The dynamic recording occurs at a minimum of 30 video frames per second, which is essential for detecting the rapid movement and the bolus flow events associated with the oral pharyngeal swallowing. Test boluses are given in increasing volumes to minimize the risk of aspiration, and different range of food textures are given in graded manner for the swallow to be assessed, and the bolus can vary in volume, consistencies, and for any abnormality in swallowing we can give postural maneuvers. Uh, just a quick note, the contrast medium that we give can either be thick or thick boluses. The packaging that comes has 340 grams of powder of barium for oral suspension, which contains 98.45% of barium sulfate weight by volume. The powder is diluted in 65 ml of water for the liquid consistency and in 30 ml of water for the semi-solid bolus. And for each density, the patient is invited to take 3 sips of 5 ml each. As you can see, penetration aspiration scale, which is totally normal, where all of the food bolus can be seen going into the hypopharynx and then into the cervical esophagus without any spillover into the larynx. PS2 may be normal. It is not that it is pathological. There is brief moments of aspiration, penetration, I'm sorry, and which is immediately cleared out of the airway and swallowed. And this is sometimes seen in healthy individuals. You can see very brief moment of penetration into the airway, but it is rapidly cleared out. PS3, it remains above the vocal folds, the food bolus, but it is not ejected from the airway. So here we can question the integrity of the superior laryngeal nerve receptors and further the sensory motor responses. As you can see, it is just staying in the supraglottis in the vallecular region, but the patient is not able to eject it out of the vallecular. PS4, it is rare. Here the food bolus comes in contact with the vocal folds and is ejected promptly. There is no material in the airway at the end of the swallow. So you can see it is at the glottic level, but it is also ejected promptly. PS5, here the material enters the airway, but it is not ejected from the airway. Here again, we can question the integrity of the sensory motor responses of both the superior laryngeal nerve and the recurrent laryngeal nerve. Here the patient is trying to cough it out, but it is still in the glottic region. PS6 is the rarest of all. It is only seen in 3% of the cases. Here the bolus enters beyond the vocal folds into the subglottis but is promptly cleared into the supraglottis. So the laryngeal vestibular closure mechanisms may be affected, but the cuff reflex is intact such that the food bolus that is aspirated is pushed back into the supraglottic region. PS7, here the bolus of the food enters below the vocal folds. The ejection response is present, but it is ineffective. There is ineffective expulsion of the bolus material. This reflects the failure of supraglottic, glottic, and tracheal airway protective mechanisms. And this suggests that there is some residual recurrent laryngeal sensory component that is intact, but the cuff reflex is weak, so that the part of the food bolus is propelled into the supraglottis, not all of it. And PS8 is silent aspiration, where there is total failure of the sensory and the motor components of the expected response. There is no awareness that the bolus material is in the tracheobronchial tree. There is no cuff reflex present, and all of it goes into the trachea. So, what is pharyngeal clearance and residues? As we all know that base of the tongue squeezes against the pharyngeal wall to push the bolus of the food forward, and then the pharyngeal muscles contract sequentially to clear the tail of the bolus, and there is anterior and superior movement of the hyoid bone along with the larynx to provide a counter force to assist the pharyngeal constrictors and the longitudinal muscles. If the clearance is affected, the residues will remain behind. So these are the normal values which is measured on videofluromanometry. The tongue base pressure generated is 130 plus minus 70 mm of Hg. The upper esophageal sphincter resting pressure is 90 mm of Hg. The contraction pressure can go up to 240 mm of Hg. The relaxation pressure is less than 10 mm of Hg. The relaxation duration is 1.5 seconds. The bolus progression happens at a rate of 4 centimeter per second. Now, this was a very important study by Eisenhuber et al., where they predicted the factors that are responsible for aspiration, and the most important factor was the amount of pharyngeal residue with an odds ratio of 8.46. Now, the pharyngeal residues, what relation do they have to age, bolus volume, and repeated swallows? So pharyngeal residues is seen in up to 20% of elderly asymptomatic individuals, and the amount of pharyngeal retention is directly proportional to the size of the bolus and the number of swallows that happen. The residues, if they are present in vallecula, it can be seen in tongue-based disorders where the hyolaryngeal elevation is affected or where the pharyngeal contraction is affected. If the residues are in the mid-pharynx, the hyolaryngeal elevation may be affected. There will be some problem with the middle pharyngeal constrictors. If the residues are in the piriform foci, then there may be some problem in the upper esophageal sphincter relaxation or opening. Here we can see the residue in vallecula. The swallowing here is incomplete with the residue in the vallecula. The residue needs to be quantified in order to understand the severity of the problem. Here the location of residues, as you can see in the posterior pharyngeal wall, piriform sinuses and the vallecula. So before proceeding to different scales, we need to understand a concept that is the swallow rest. We need to quantify the amount of residue. Okay, but for quantification in a particular location, which frame to select? So here comes the concept of swallow rest. The first frame showing the piriform sinuses at their lowest position relative to the spine, and where the first swallow ends and before the onset of the second swallow or any non-swallowing event like coughing or aspiration, that frame is called the swallow rest. And then we use pixel based measures using software
Retained
to quantify the aspiration. Now, the first scale is a bolus residue scale, which was given by Rommel et al. In 2015, is a visual perceptual scale of the presence of the residues. So it is graded from 1 to 6, where 1 there is no residue, and 6 where there is residue in all the three spaces, that is the vallecular, the posterior pharyngeal wall, and the piriform sinuses. Then comes the Eisenhuber scale. It is also a visual perceptual estimate to which a space, for example vallecular or piriform sinus, is filled. It is given in percentage of the space filled, 0 to 25, 25 to 50, and more than 50% of the height of the space. Now here the percentage filled space by width was given by Han et al. In 2001, and it is graded from 0 to 3, where 0 there is no residue, 1 where there is less than 10% of the width of the vallecula, 2 is up to 50% of the width of the vallecula, and 3 is more than 50% of the width of the vallecula. Then a two-dimensional ratio was given by Dyer et al. In 2008, where the height is multiplied with the width of the vallecular residue, that is H1 into W1, which is the height and the width of the residue present in that particular space, multiplied by the height and the width of the dimensions, that is the actual dimension of the space. Then we have dynamic imaging grade of swallowing toxicity, or the digest score. It was given by Hutchison et al. In 2017, and here the bolus clearance is measured compared to the bolus which was originally given as part of the study. And this is again a visual perceptual estimate of the residue. Then Leonard gave a bolus clearance ratio, where the residue area was divided by the bolus area on the frame prior to the upper esophageal sphincter opening. Now we can have some quantitative pixel based measures of the residue area. For example, the normalized residue ratio scale, which was given by Pearson et al. In 2013. Here the area, the square area from C2, the lower border of second cervical vertebra, till the lower border of fourth cervical vertebra is taken, and they concluded that the pharyngeal space is around 58% of the area of the square that is calculated, and the percentage of the residue, which is denoted by letters alphabets A and D. The area of this A and D is measured and is taken as a ratio to the area, pharyngeal area, from C2 to C4. Another scale was given by Steele Mukherjee et al. In 2019, where they calculated the area A plus the total area of that particular space. For example, vallecula here. So B is the space of the vallecula that is not filled by the bolus residue, and A is the area that is filled by the bolus residue. So A upon A plus B into 100 was the formula given by Steele and Mukherjee in 2019. So what are the limitations of these measures? First of all, the selection of the frame can be variable between the observers. Then the concentration of barium is also important. If there is more concentration, there will be more coating of the mucosa with possible misidentification of the presence of the residue. Then how much amount of residue needs to be present to be called as present is also questionable, and is not generalized or standardized by any study. Plus, these two-dimensional videofluoroscopic measures do not properly capture the 3D nature of the residues. But we have seen that it is usually around 91% of accuracy when we use three-dimensional measures using computed tomography. So now we come to foreign bodies in the aero digestive tract. So foreign bodies can either be inhaled into the airway, or it can be ingested into the digestive tract. The impaction of foreign bodies in the trachea and bronchus poses a life-threatening emergency. So what are the most common foreign bodies in a digestive tract? It can be the coins, which is the most common, fish bone, sharp objects like nails, pins, blades, button batteries, food impactions. It can be magnets, it can be dentures, or meat or chicken bone. So these are the most common objects seen on a flexible esophagoscopy in the digestive tract. There are three most common sites of foreign body impactions, which can be the cricopharyngeal constriction, or at the site of aortic constriction, or at the region of inferior esophageal sphincter. The foreign bodies in esophagus patient will present with symptoms of dysphagia, drooling, patient not accepting feeds, gagging, emesis or hematemesis, foreign body sensation, dyspnea, chest pain, or fever. If the foreign body is in the stomach, the patient will present with abdominal pain, abdominal distension, vomiting, hematochezia, or any unexplained fever. So how do we differentiate a foreign body in the airway of the or the foreign body in esophagus? If the foreign body is in the airway, it will appear as a slit-like projection in the anteroposterior view and a circular projection in the lateral view. But if it is in the esophagus, it will appear like a circle in the anteroposterior view and slit-like in the lateral view. This is how the foreign body gets oriented in the trachea and in the esophagus. The foreign body aspiration, it is the most severe form of emergency, and it is more common in the age group of 1 to 4 years because they start putting every small object in their mouth. They are running and chewing at the same time, and history is not forthcoming many times, and there is a wide variation in the clinical presentation. The presentation can be either acute or which is less than 24 hours of presentation, or it can be delayed, which is more than 24 hours after the foreign body aspiration. And delayed diagnosis or late presentation is associated with severe complications of aspiration pneumonia, atelectasis, mediastinitis, etc. Here we can see a foreign body tooth that is obstructed the airway. So what are the common types of foreign bodies? It can be either organic or inorganic. The organic foreign bodies, they tend to be causing more severe form of airway obstruction because first of all they are lipophilic, which causes intense inflammation and granulation tissue formation in the airway, and they also absorb water at the same time, whereby any partial obstruction or a very small foreign body causing partial obstruction is converted to total obstruction in a short duration of time. Compared to organic foreign bodies, the metallic foreign bodies, they cause minimum reaction. So the location of the foreign body, it depends on the size and the consistency of the foreign body, and it can have varied presentations. If the foreign body is stuck in the larynx, for example in this image, it will give rise to hoarseness, aphonia, dyspnea, or wheeze. If it is in the tracheobronchial tree, it will give rise to unilateral wheeze, decreased breath sound. And if the foreign body has a lumen, for example, a ballpoint pen cap, the patient can respire through the lumen. That is, they can inhale and exhale through the lumen, and the patient will be asymptomatic most of the times. So, what are the most common findings in a chest X-ray? There is usually unilateral air trapping, which gives to a darker area where the air is trapped. This gives rise to hyperinflation of that ipsilateral lung field. The bronchovascular markings are also present. It gives rise to a flattened diaphragm. In some X-rays, you can see localized areas of hyperinflation, atelectasis, and rarely air leak. So this was a very important study given by Kaliskan et al. In the year of 2018, where when there is rotation, the child is usually not stable when we are doing the imaging. So the child rotates while we are taking the röntgogram. So the chest field, which is more towards the source of the X-rays, it receives more proton beams and it appears more radiolucent because of more penetration. So that gives a false positive result of a airway trapped in that particular lung field. So they gave the concept of radio density ratio, whereby they compared the different the both the lung fields, and they saw that when the radio density ratio is more than or equal to 1.10, there was more chances of a foreign body being trapped in the airway, and they suggested a flexible fiber optic bronchoscopic evaluation with removal or a rigid bronchoscopic removal, and if it was less than or equal to 1.10, they suggested a computed tomographic scan. So which patients should be taken up immediately for surgery? If the patient has battery in the esophagus, if the foreign body is more than 10 centimeters in longest dimension, if the patient is symptomatic, that is, their features are suggestive of perforation, if the foreign body is a sharp pointed object, if the foreign body is in the esophagus for more than 24 hours, or if the foreign body, for example patries, is in the stomach for more than 48 hours, we need to take up the patient for immediate removal. So that's all for today. Thank you so much for patient listening. Thank you.